Hello, everyone. Today I have Dr. Claude Robinson here, Ph.D., to introduce himself, and we're going to talk about how to best support experiencers. Can you please tell people more about yourself?
Yep, I can. As you said, Deb, my name is Claude Robinson. I'm a licensed clinical psychologist, currently working in private practice in East Tennessee. And I see a host of different populations and folks for different things, including forensic work, working with veterans a great deal, lots of evaluations, some active duty, military, and then a whole host, of course, of just folks across the age span dealing with depression, anxiety, PTSD, all that kind of stuff. So, but yeah, and I guess how I help or interact with experiencers. It's a funny story. Uh, it, I was never really interested in this topic um, the way I am now. Prior to, I would say, 2015, 2016, I had some folks who were like friend of a friend kind of contact me and say, hey, there's this person, who's making these really interesting statements and claims about having experienced things, and you're a psychologist. We'd love to get your take on it. And I thought, well, okay, sure. I'm not busy. It's Friday night. I'm not going anywhere. Um, and so I kind of worked through and gained this individual's trust, and that experience left me with more questions than answers. So I started reading about just about everything that I could get on the topic. Um, but I've been very reticent up until probably this year of putting my public face forward professionally and saying, hey, I think that this is a population that is not being served, and there's just a lot that we don't know. So I do have some active patients right now who identify as experiencers, and their stories range the gamut. If you can imagine it, yeah. Um, so it's a fascinating area of work, and I just think a lot more needs to be done to help that population.
Okay. And what are some of your barriers, other than obviously it's not commonly something we get trained on? What are some barriers that you're having with helping that population?
Yeah, well, obviously the one big one is stigma. If I introduce myself, at a work group or something, and say, "Hey, I'm a psychologist," no one really bats an eye. They're like, "Okay, cool. What do you do?" But if I say, I'm a psychologist who's interested, among other things, in helping this population of people who have anomalous experiences, eyebrows go up, and folks are kind of wondering, like, does this guy need to be working with people? Is he, you know, does he have a good grasp of reality? Um, so stigma is definitely one of the big barriers, and I would say the others are, there's just a lack of support for people who are doing this work. I've only recently discovered, UAP Med, of course, and Opus, um, and started to kind of dig in there and learn, what I can. Um, but there's just really, right now it just feels like a skeleton crew. Of people who are given their time, they're volunteering essentially, right? Trying to make things better for everybody, and there's just not enough hands. Um, so I think that's another barrier. Um, and yeah, probably the biggest concern I have every day, when I'm working with experiencers, is, am I doing what is helpful? Am I doing what is supported? But the problem is that my profession, and yours as well, I assume, doesn't really acknowledge anomalous events as something that is worthy of scientific study or empirical reasoning, and this just automatically kind of goes into the woo bin and say, well, that's not something that's worth our time or effort, or, or even worse, that individual is mentally unwell. They have this diagnosis or that diagnosis. So there's just a lack of standards of care. Um, so I try to be very careful and just really, really um, listen to what the person needs, um, and then try to pair it up as best I can with what's available in the literature and through consultation, even though sometimes I have to kind of maybe talk in code.
Right. So one of the issues about psychology is that we really try to do evidence-based treatment based on positive outcomes, and we try to match it up with the diagnoses. So I think when we're talking about dealing with anomalous, what I tend to say is probably best to just focus on the symptoms and try to treat those. So I imagine that um, you have some input on that perspective.
I do. Um, and yeah, I agree. I don't. I'm very agnostic. Even after a handful of years researching this topic, I'm agnostic. I don't know. You know, if there are little green men from Alpha Centauri or whatever, coming and visiting. I have no clue. Um, what I focus on in my professional work is if someone comes to me and says, "Hey, this is how this is affecting me. These are the symptoms that I'm having." Then yeah, I try to target the symptoms, because at least at the micro level, that is enough for me to kind of defend the work and say, "Well, look, someone can come in and tell me anything. My job is not so much to be the arbiter of truth, but rather to say, okay, you're suffering, and you're telling me that this is your rationale for your suffering. What can we do to limit your suffering?" So, we focus,
Yeah.
as you said, on the symptoms.
What do you think people are doing currently beyond yourself within mental health that they should stop doing if they have someone come with anomalous experiences into their office?
Yeah, good question. I think the first thing is they need to stop automatically having this knee jerk reaction that, they're delusional, they're having a psychotic, break, or um, there's some sort of trauma, going on here, and that's causing, um, so just automatically making an assumption. I mean, we wouldn't do that for someone who, came in and said, look, um, I've been really sad since my, you know, parent passed away, um, or I've, you know, been really worried and I have trouble. Um, Remembering that I turned the stove off or whatever. I mean, we don't stigmatize folks with those issues and those symptoms. So I really would encourage other practitioners to not just automatically you know put someone's narrative in the woo cabinet and say, well, yeah, we're not going to pay attention to that, because I think you miss a lot of opportunity for connection and information gathering. And yeah, I mean, I think that you have to have the discussion about diagnostically what may be going on, but the diagnosis is not the person. The diagnosis is just one way to understand their suffering and to try to be helpful. So I guess the second thing would be to not mistake the diagnosis, you know, for the person, and therefore make an error where we're throwing the baby out with the bathwater. Um, So, if this person, for example, has this particular diagnosis, then that must mean that everything they say or all of their behavior has to be put through that particular filter or lens. I think that's just horribly, horribly unfair and unethical. Um, so, yeah, diagnosis has its place. I mean, I'm a clinical psychologist, so I enjoy thinking about problems in that way, but I don't think it's good to take people with these kinds of experiences and say, well, you must be, and so therefore
Right.
I'm not going to be helpful.
What are some of the diagnoses that you're seeing associated with anomalous experiences?
Um, if I clarify your question just a little bit, I would people who have these experiences have the same likelihood I find of all the other you know likelihood of diagnoses. So someone who has had AHI or an experience is just as likely to at baseline, prior to be depressed or anxious or whatever. Um, but certainly when they have these experiences, that seems to kind of push the diathetic stress point, you know, past what they're able to really manage. That's oftentimes why they come in and want to talk to me or want to get some guidance. But yeah, I would say that for folks who have no mental history, and this is where I'm making the distinction prior to their experience, what I tend to see is a lot of PTSD, like trauma type symptoms, um, and something that's kind of unique. I don't think there's really a diagnostic category, at least not in the DSM for it. But I've been reading and hearing a lot about lately this term called ontological shock, um, and and I know you've mentioned it, so you know what that is. But people coming in and saying, "Look, the way I viewed the world, the way I viewed myself, my relationships, my work, all of that was one thing before this incident happened to me. And now, since that incident, all of those definitions have changed. And so there's like this loss of identity, there's this grieving process that's happening, there's this confusion. Um, so I guess you could break those down diagnostically as, you know, depression, anxiety, but that again, that doesn't really describe the full richness of what the person's suffering is like or what they're dealing with. And it just kind of takes the humanity out of it. Um, so, ontological shock, helping people deal with the fact that they've changed, and you can't unsee, you can't unring a bell, right? So once you've heard it or once you've seen it, it's there in your awareness. So, helping people with that has been a huge challenge for me, um, because this kind of touches on not just their psychological viewpoint, but also their spiritual or religious viewpoint, their sociological viewpoint, just so many different facets.
Right. And I also feel like, and I think it's worth noting that the country and the world went through something similar with the COVID pandemic. And I'm still seeing that clients are struggling to come back to normal, especially those who, a lot of my clients are children. So for them to come back into the school system and have to readapt
Mhm.
after having been at home, and relearn how to be social again has been a struggle and still remains a struggle for some of them. So I think it's sort of compounding. If they're also someone who has an anomalous experience, they're still dealing with the social sort of depression that we're all dealing with from dealing with COVID.
Hmm. Hmm. No, that's a brilliant point, um, and it's a good example of kind of how um, everyone was forced in one way or another to deal with the reality of COVID. And as I'm sure you know, that ranged from disbelief, distrust, conspiracy theories, all the way through to acceptance and people just checking obsessively every day. And I was probably in the latter group. Well, okay, how when do I wear my mask? How close am I supposed to be to someone? How often should I test? Because I was working throughout the pandemic. I wasn't able to stay home. Um, I mean, I did some hybrid work, so I don't want to be inaccurate there. But yeah, so adjusting back to that reality is kind of like what people are experiencing, I think, with these anomalous experiences. And Deb, if I could, I would like to just say that for me, another huge challenge, and this is probably one, I guess, I hope it's one that other professionals are also experiencing, is not knowing who to trust or who professionally to go to consult with, or to get information from. It's one of the reasons why I appreciate UAP Med, and the work that you and others have done by, putting um, research, peer reviewed journal articles in the forums so that people can go in even anonymously, look and see. That's just a huge help, um, because I could pick up, at the local bookstore, 10 different books about the phenomena, and it's going to range from the absolutely fantastic, this is pure fiction, maybe, uh, probably, to, this is all just in people's heads and it's not something worthy of, serious scientific thought or care. So it just seems there's such a broad spectrum, and I I try to be careful about what I read and what media, that I'm partaking in, especially with this topic, because again, I think it's so important for practitioners to stay agnostic. That's something that Ted, the director of our group, has said, and I really appreciate that mindset. Because otherwise, how do you? It's just too easy to get lost in a rabbit hole.
Right.
Um,
And I tend to put everything on the table is what I say. I like to speculate on certain things. I enjoy the idea of certain things, but I also think there's possibly multiple things going on and we just don't know. And it's not overly beneficial to hold on to one set of ideas or a dogma when you're, especially when you're trying to help an experiencer, especially because, like you said, they have such a wide range of experiences.
mhm.
And there's also, sadly, that possibility that some of those are manipulated experiences, and then it's a scary thing to think about for some people, I know, but we don't have full clarity yet. Um, and then someone who plays video games, I just can't like discount
Same.
the I just can't discount that some of this is like some kind of technological issue. I don't know. Like this is just an idea, but it's just, so again, it's kind of fun sometimes to speculate or scary, but we really just don't have that answer and it's not very helpful to stick with one idea when you're treating someone.
Hmm. Yeah, and for me, in my work with experiencers, I try to just take it to a very baseline level where I'll say, okay, well, I may not have direct knowledge of, what you're telling me, or, I may not have had those types of experiences exactly, but I'm willing to at least listen to you and to try to bring you some sense of peace about it, or um, help you work through those symptoms that are kind of the result. Um, but yeah, it's kind of like the Wild West out there when it comes to, you know what do you spend time in thinking about, reading about, um, listening to. I mean, there's all these folks who, and I'm not going to name any names, but just are very, very, very public. They're very much so in the public eye, and they have books and tours and events and just all these things, and they're almost these magnetic, sort of personalities, um, who seem to pull people in, and that always makes me nervous. So
Yeah,
um, I like simple things and simple people and folks who, when I sit down with them, I can kind of feel, okay, this is their agenda, uh,
right.
and know it and feel it, and that makes me feel better about the information that I am sharing or that they're giving me.
Right. And it would be really helpful if we could get some more clinicians to sit down and say, well, this is what's going on. We don't really know what's going on beyond this. We don't know why.
Hmm.
So how can we help these people? Because that is supposed to be what they're supposed to do. They're not supposed to cause secondary trauma by telling the person that they're crazy.
Right.
Um, and one of the things that people don't know is that, in that gathering of literature, we've really seen a wide range of what's going on, from there's no mental health issues other than that experience, and all the way over to, there's schizophrenia. So, like, it really, there's a huge, wide range of thoughts on it and not a lot of clarity. And ultimately, the best we can do is determine best practice.
Yeah, yeah, and I think, and I'd be interested in hearing your thought on this, Deb. But I think in order to get to a set of best practices, there has to be this sort of reverse engineering of, you know, how the profession, and I'm speaking of psychology here. I can't speak for other, because I'm a psychologist. That's the only thing I do. Um, but looking at how psychology has come to this current state of understanding or awareness, or lack thereof, about people who have these experiences. So it seems like, you have to go through the entire history of how did we get here in order to identify, oh, well, that was a misstep, or oh, that part was really good. This panel or that research group did a really good job here, and then scraping those guidelines together. I think that's how we can get there, as a profession, but that would mean folks would need to be willing, um, to have the conversation and see value in it. But
Right.
what are your thoughts?
So one thing that's interesting about psychology is, when I was getting my degree in psychology, they often called it a soft science. So, what I think you're proposing is, okay, we're a soft science, let's change the hypothesis. So, instead of someone who sees something anomalous being immediately assumed to be, delusional, let's change the hypothesis and test that and do some work on that. So that's where we need to go, I think, ultimately. We have also talked about some other systematic changes, but I do want to point out to people who are not as familiar with the field of psychology that it has changed tremendously over the years, and it's actually kind of young. It's not that old. A
Yeah.
lot of people, say like Freud was the father of psychology, like it kind of started then. That wasn't actually that long ago.
Hmm.
um, and actually, a friend of ours, Ron Westrom, was talking about in other cultures, they just have a bench and people come and sit down, and the people in the community come and sit with them. And, they just chat and support each other. And that's also psychology and helpful.
Hmm.
So, it'd be great if we could adapt some, less stressful ways of helping these people too, I think. But, um, I guess my point is, we do change, we're able to change, but maybe we should start with trying to change the hypothesis and get some data.
Definitely. And I'm watching the news and these congressional hearings and whistleblowers and this sort of stuff coming forward. And what's interesting for me is that with the experiencers that I'm treating, like they're seeing this stuff too, and they're not really surprised. They're like, yeah, okay, yes. Can the rest of the world now catch up to sort of where I am, and so that we can start getting some answers and some clarity and some guidelines, and maybe a better sense of which way is up. Um,
Right. And I think the
so
poll recently said it's like 60 some percent of Americans believe UFOs are real. And there's like a pretty high percentage that think there might be aliens on the planet, So, whether or not they're aliens is, really beyond the point for me, right? The
same.
point is that people are starting to think this way, right? And I think it would be helpful to professionals if more people were honest about that and it wasn't a closed door discussion and it wasn't a taboo discussion and people could be more open. So, one thing that I've done before is I've created talking points
Hmm.
for people to just open the conversation. And it's interesting how often, like, I'll just say something like, "Have you ever had a psychic dream?" or "Have you ever had deja vu?" And I'm sorry, an ambulance is now going by, but I don't know if you can hear that, but
Okay, it's
um,
okay.
right. And a lot of people will say yes because it's a shared human experience. So, I think if people were not so afraid, like I have a great example. I was having a conversation with my dad about my interest in this topic, and he told me to stop talking about it and shut it down. And this was on a Halloween night,
Hmm.
and he said it would ruin my career to have an interest in this topic. But then we go inside, and my sister's telling ghost stories, and I'm like,
Yeah.
"What? So why is one okay and the other is not? What happened? Why is this created stigma that powerful that one ruins your career, but the other is we're going to share those and it's fun and we're going to have like coloring pages for ghosts and decorate our house with ghosts.
Hmm.
I don't know what happens.
Yeah, I, I don't know. Again, I think it goes back to that whole idea of ontological shock, where like I'm from Appalachia, and so we have you know this whole cultural experience surrounding haints, spirits, oftentimes family members, that kind of thing, and it's people will sit around the dinner table, and talk about having seen um, grandmother so and so or uncle thus and such, and it's like, yep, yep, that's beautiful, that's absolutely, you know that's valid. But then you start talking about, well, there were these weird lights in the sky, and I don't know what they were, and I don't think it was a plane, and you could just feel the temperature in the room kind of drop. um, so it's almost like it's like one is culturally has been accepted or given a place to land, with the ghosts and that sort of thing. Whereas with lights in the sky or little green men or whatever, um, there's no place to really put that information, and so people rely on stigma or rely on the sense of discomfort, like, I'm outside of my bounds here of what I normally think, and what feels okay.
Yeah.
um,
It's definitely kind of a damned if you do, damned if you don't kind of thing too, because people get very sad about the idea of us being the only living intellectual beings creating art in a universe. But then on the other, like, which scientists, by the way, say that's not true. That's not likely. That there's so many different planets, but whatever. And then on the flip side, if you say, okay, we're not the only ones, people are like, let's not talk about that. And they start looking kind of weird at you, look at you a little askance, like, which
yeah,
one do you want, people? Do you want to be all alone in the entire universe or not?
yeah, but you have to pick. If you're setting the argument up that's one way or the other, then okay. um, but you can't have it, yeah, both ways. um, so no, I think that's a fair point. And there was a thought I had, it's escaped me. Continue, it'll
Well,
come back.
I think you did touch on something that I wanted to address, and this is something I've said a few times also. I think there should be cultural sensitivity to this topic. I think, it'd be great if it did become part of mainstream culture, as you said. And I think most clinicians are trained for that, but they do leave this out when they do that training. For instance, I've done cultural diversity trainings where they talk about some cultures believe in ghosts, and
Hmm.
you need to um, respect that culture and that belief. In fact, I just did that conversation with Farouk McDermott about, Muslims believe in the jinn,
Hmm.
and that's
Yeah.
part of their cultural belief. So if someone comes into therapy talking about ghosts, or jinn or whatever from their culture, we are supposed to respect that.
Hmm.
So if someone sees a UFO and has a cultural belief that that's a standard for them, we should be respecting that too.
Right.
So I don't know. What are your thoughts about the cultural sensitivity issue in therapy?
Oh, you're giving me an easy, slow pitch, Deb. I'm going to try to knock it out of the park for you. Yeah, I think that is definitely one of the things that we need, is to realign the discussion of, well, this isn't a matter of delusional versus not delusional, or crazy versus not crazy, or whatever, but this is a matter of cultural sensitivity. If someone comes and says these things, it is not my place to say, well, no, if that's your viewpoint, that's wrong, or if that's how you view the world, that's not okay. That would cause harm, right? But I cannot tell you how many experiencers I've worked with over the years, since about 20, again, like 2015, who come to me and they say, well, I didn't tell you this at first because I didn't think you would believe me. My last therapist didn't believe me. Or they said I needed to be put on these really strong medicines. And, I mean, I've worked with police officers, politicians, physicians, other mental health professionals, um, fire and rescue, active duty and military, who all have said they've had these sorts of experiences. And I would never, ever, ever, you know, make the assumption that their worldview, though very different from mine in certain places in certain areas, that it was somehow less valid. So I think we need that as a profession. We need to reorient the discussion and make it one more of cultural sensitivity. Um, I saw it was a meme, or an infographic rather, a few weeks back, and it was like a pyramid, uh, and the higher up you went, the more quote delusional your thinking was. Like if you believed in certain things, and I'm like, oh, well, this looks interesting. What's this? Um, and basically, there were three broad bands. Like the bottom band was, well, probably delusional, but benign. And then that's where it had like UFOs, aliens, that sort of thing. And I thought, wow, okay, I don't think that many people I see are delusional. Um, and then it went up to like Pizzagate, or um, all these conspiracy theories, on and on and on and on and up, until you get to really weird stuff like um, a particular politician or world leader was a reptilian alien in disguise, or I don't know, Biden's been replaced by a robot. So, but in looking at that, I was like, you know, but what about now? We have these whistleblowers, people who seem very credible, um, no history of mental illness, who seem very honest in what they're saying, great careers. At what point as a society do we get to take that one section out of the delusional rubric, whatever you want to call it, and say, well, no, that's a different cultural viewpoint.
Right. I have a question for you on that. Did that
Yes,
pyramid include religion? Did it include
I
God?
I don't remember that. I don't recall that.
Right.
You're making me a
So
little uncomfortable right now, Deb.
I know exactly, right? You see what I'm saying? Like
Yeah.
people, if we understand that for some people, they see an object that's undeniable, they see something, right? The
Hmm.
government is saying something is there, but then they add a level of belief or thought about what it might be. The belief part is where people are forgetting to be culturally sensitive.
Good point.
So the object is undeniable, right? Even if it's a balloon or a plane or natural phenomenon or a UFO, we don't know. It's there. They saw it, right?
Right.
But but the problem that people have is when we get to the belief part, and I was trained to respect other people's beliefs in
Mhm.
a therapeutic setting. You do not
Likewise.
tell someone whether or not you agree or disagree with their belief in God, for instance. You just let them tell you what their belief is, and you respect that, and then you treat the symptoms. So I
Hmm.
think that's, a lot of people are making this mistake of going, "Oh no, you think it's an alien. There's something wrong with you." Like, well, that's not how we were trained. Like,
Mm-mm.
so, well, who's lacking in that cultural sensitivity?
Right. Right. Yeah. No, I would never, ever sit down and tell someone, okay, so you think that you saw, Jesus or Buddha or whatever, um, and well, that must mean you're crazy. I would never, ever, ever in a million years say that.
You would
And
get
if
in
I
so much
even,
trouble.
oh gosh, that would be bad. That'd be a very bad day, super bad day, um, for me and the patient. But no, and it's one of the reasons why I decided to kind of come out and be a part of UAP Med. Uh, I think I do some work. Um, it's at very early stages with the mental health portion of the team, I think is what we call it. But I I no longer care what other people think. If someone thinks that me doing this work makes me odd or um, in some way not a good actor, then okay, fine. But until you can find a problem with what I'm doing, because I try to keep my nose clean, follow all the ethical guidelines, do everything I can to be a good human and a good provider. Um, so if someone raises an eyebrow about my interest in this or whatever, it's like, well, okay.
I think I also want to add that, as we do respect those beliefs, we're not, it's not our place either to encourage them either. So, like, we just let them have them, like
Hmm.
on the flip side of that, we would never say, you really have to believe in Jesus or you really have to believe in Allah or, we would never tell anyone that.
Yeah, I'm. Somebody comes in and I tell them, whatever it is that's important to you, that's what's going to be important to me. For me to be helpful, I have to understand the way you view the world and how you view your problem and how you make meaning out of your struggle and what's going on. It's that simple. Um, I'm not willing to die on any hill that says that, like I said before, that this is just nuts and bolts craft or just consciousness or some mix of the two. I don't know. I am very, very low on the food chain when it comes to specialized, secret, top secret information or knowledge. I'm just a consumer like anyone else. What I get on the news.
Right.
So I'm not going to deign to say, well, no, you have to believe this or you shouldn't believe that or what. Nope.
And I also want to say that as someone who's attracted to this field, I think, everyone I've met attracted to this field really wants to help people. But also, there's just kind of this love of humanity where we also see humanity as it generally is, but we love humanity, and it's a sad thing to see humanity discourage discovery because it's a part of humanity, right? It's a sad thing to see humanity not
Oh.
support each other, right? That's like a part of
Mhm.
humanity generally too. And I do think we're doing better slowly but surely with being better humans. Like, we like, generally, you see humanity trying and making an effort to be, um, more respectful of each other, more appreciative of each other. It
Mhm.
is taking some time, but I think honestly, part of me is like, this is like the next civil rights movement in some way, you know? It's like the right to have this belief too.
Mhm.
Um, so I know it's probably not something people want to hear or agree with, but it's just
Well, no, I so feel what you just said and appreciate it because it's, you know, another reason for me coming out, another reason for me doing the work is I'm not going to let anyone affect my ability to be curious or to be empathic or to be caring about another human being. I refuse to let that happen. Um, so I may not understand it. I may not know a lot about it, but I'm not going to turn someone away because of my personal biases or me becoming unwilling to at least be curious, or to wonder how this person may be helped. Um, I refuse to become that jaded person. I won't.
I think what we've discovered in this conversation today is that one of the facets of best practice will just be the learning curve and self discovery for the practitioner. And do you have any recommendations for someone who hasn't had a conversation with a client yet, but may, anticipate having a client who wants to talk about this? Do you have recommendations about literature or anything else for someone who will eventually be having this conversation with somebody?
Oh, that's a great question. Well, I would say, we treat it how we would any other, problem that maybe I'm not familiar with. Uh, do research, stick with peer-reviewed journals, articles. Um, Look for Opus, UAP Med, because I don't know as much about Opus. I'm only just now kind of, entering that organization, but it seems like there's a real value placed on, empirical um, curiosity, as I call it. So yeah, networking with other providers who are doing this work, avoiding the if it feels woo or it feels uncomfortable or like you're just you know being pulled down this rabbit trail, come back. Come back to how do I help this individual? What are the symptoms? How do I use best practices based on what I know for those symptoms? Um, and just keep having the conversation, both with your patient, client, and with the extant literature and people actually doing the work.
And I do think it's really important that you mentioned getting some peer support for us, right? Because we're trying to kind of deal with all this data too.
Hmm.
Imagine how much, mental health would have improved if we had had mental health during COVID. Like
Oh goodness, yeah.
because that was hard for practitioners too. Like, I had to adapt to being in my house every day, doing Zoom sessions for my clients. Back to back to back. My kids couldn't be in the living room because I was doing Zoom sessions back to back to back. That's a big way of adapting for us too. So it is a good idea when you're dealing with things that are difficult, new, or overwhelming to touch base with someone else and share ideas and thoughts and get that support.
Yeah, and even if I think what the person is telling me is not useful or it's way off base, that's helpful because it tells me where I don't want to put my energy or what I don't feel comfortable exploring. And so then I can turn away from that and say, well, okay, well, if I go back to the symptoms and back to, best practices as they are, how can I be helpful? That's useful too. I think a lot of folks are just afraid to have the conversation, and I'm not.
Right. And I will just share that for me, my clients who have said something about something anomalous, which is, by the way, sometimes not related to UFOs. Sometimes it's something else, like a ghost, or I've
Hmm.
had one person talk about like an angel or something. I just let them talk, you know? I just let them give me the information, and for them to have it normalized, it's not a big deal because, like I said, most of them are children. So, like, if someone just normalizes it, it doesn't become like a huge traumatic memory for them, and then they move on.
Yeah,
So,
yeah, I agree. Preaching to the choir.
right. And I think that'd be great if we could just remember, all these things that we talked about, getting peer support, doing the research, sticking to your own instincts with it, looking at the facts, and, letting yourself go through the curve, of the learning curve, and accept what you can, and remembering our cultural sensitivity. And the reason I brought up the civil rights issues, because this community has been severely ostracized. A lot of people have been fired. Some people have been treated very badly, and including some of them have committed suicide because they weren't treated well. It's pretty tragic. So you don't hear about that with some of the other groups. Like you don't hear about some of the other people going to therapy and feeling so bad afterwards that they go out and get fired and stuff. I don't know. It's very different.
I think along those lines, another thing that professionals can do is you have to be willing to acknowledge where you as a professional have biases and acknowledge where you may automatically um, feel yourself pulled, in a process or in a discussion, and kind of check yourself. I have some, you know, um, fellow psychologists I work with. For just as one example, they would never deign to consult with someone unless it was a PhD level psychologist, and I find that so odd. I find that so unhelpful. They like social workers or other licensed professional counselors or just whatever. Lots of times, and thank God it's not a lot, but it's enough to be problematic, at least in the area where I am. They say, well, no, if you don't have the particular degree, then you're not going to have the experience. You're not going to be able to understand the language, and I think that's just garbage. Um, so
I'm
when
I'm I'm
someone,
laughing in my head because I've complained about therapy language. In fact, at one point I wrote a book about how to translate that for clients, because it's not actually for you that you have that language. It's supposed to be for your clients.
yeah, yeah, and I think the same thing happens with a marginalized group, like people who are experiencers. It's like, okay, there's like this different tier system of, well, this is a legitimate patient or client who's coming in, and oh, there's this one who believes in little green men from Mars or whatever, and that it just connects to this whole idea that there are different tiers and therefore different values assigned to people based on their job, their educational status, that kind of thing. And I yeah, that it just baffles me. And I see that more so with folks who have experiences. So I think that's a red flag that says there's something happening here in regard to marginalization. Um, because if we say that it's okay to treat one group a certain way because of whatever reason, and we don't hold that same standard to other groups, then that's not cool.
Well, unfortunately, I've also seen people who just don't like anyone who believes anything. You know, I mean, I mean it. Like I've seen that too. First, they complain about someone believing in, say, aliens, right, or alien greys, like the one species that is commonly discussed. But then they turn around and complain about someone believing in something else. So I realize that's more about them than it is about the experiencer.
Yep.
And I hope more experiencers recognize that that's not about you. That's about them. It's about that
Mhm.
bias that you mentioned. It's about something in them that they need to work out. And in the meantime, we'll hopefully remember not to take those things into sessions, because we shouldn't be anyway. Um, I don't mind saying that I'm not a political person, but there were times when people wanted to tell me about their political views, and I had to just keep my mouth shut because it's not appropriate, in a session to share what your political views are.
No.
It's so
Mm-mm. Yeah. Time is better spent by saying, okay, that's really interesting. Can you tell me more about how that affects your problems? You know, does your particular political viewpoint help you deal with stress, in a
Mm,
certain way, um, by aligning with one political figure or another? Does that, in some way make the world make more sense for you?
right,
So, I mean, I don't know. To me, it just seems like, duh, just talk to people. Don't be
right.
judgmental and don't be a jerk.
I know, I know. And I hope that people hear you on that. Can we use that as a quote on UAP Med? Duh,
Oh
don't just,
God,
I'm just
I,
kidding.
I'd rather you pick something that was more eloquent or polished. But
Of course, of course. I'm just kidding. I'm just
CJ
gonna
says,
think.
duh.
I'm just gonna think about it in my head from now on. When people are trying to have these serious talks, I'm just gonna go, duh. I'm just kidding.
Just give
I
me
don't.
credit. Just give me,
Of course, this is a quote. Well, thank you so much for coming and talking to me today and giving us some things to think about best practices for how to help people who have had encounters with UAPs or non-human intelligence. I truly appreciate that you gave us your perspective and all of the work that you're doing. You're an amazing person,
oh,
and we're very
thank
lucky
you.
that you care about helping humans.
Hey, it's what I'm here for.
Right.
Thanks so
Is there
much for the
any
time.
of cool, thank you. And do you have any final thoughts that you want to share with people?
Oh, final thoughts. Be open, be curious. There's so many awful things going on in the world these days that say that we need to be angry with one another for this reason or another. And I just don't want this topic to be one of them. Um, so um, find something to connect on and just have conversation. Maybe get to know each other.
Do you want to tell people any way that they can reach you if they have questions?
Yeah, sure. Probably the best way is my email address. It's drcj at robinsonpsychological.com. Kind of long, but um, and then my website is robinsonpsychological.com. People can go on there and send me a comment or a question or whatever, and I have staff who check those messages every day. So, but yeah,
I also do have that linked on the UFO connector under experience or support because
thank
y-
you.
yeah, so people who are seeking assistance in your state will be able to reach out to you. For people who are not aware, clinicians can only treat people that they have participation in the board of that state with. If that makes sense. So I don't know if I'm trying to explain it, but basically the license has to be state bound. Some people do have multiple states, but it's not very common.
Yeah, I'm working for this population specifically on SciPact. Um, so I'm hoping um, that I'll have that done. I just got my National Health Service Provider endorsement and credentials banked, so that's like one of the major steps towards SciPact, as I understand it. So, but yeah, hopefully I'll be able to help folks in other states soon. So, but I got to find time to do it.
If it helps to motivate you, there was this guy named Dr. John Mack, and we don't have a Dr. John Mack anymore, and he was helping people at Harvard. So,
I don't know, Deb. I don't know if I'm John Mack material. I'm kind of like Freud meets Hee Haw.
that might be exactly what people need. You don't oh, I don't know. We'll
Maybe,
see.
maybe, but I'll, I'll
Well,
I'll keep that in mind.
okay. Well, thank you again so much, and to everyone who is listening, thank you very much and take care.
Thanks, folks. Thank you, Deb.